You're listening to Medscape's In Discussion series on systemic lupus erythematosus, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Maureen McMahon. Dr. McMahon is a professor of medicine and associate chief of rheumatology at the David Geffen School of Medicine at UCLA. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Maureen McMahon. Welcome to the Medscape In Discussion podcast series on systemic lupus erythematosus. Today we'll discuss the dermatologic aspects of lupus with our guest, Dr. John Edminister. Dr. Edminister is a board-certified dermatologist and assistant professor at Wake Forest University School of Medicine. He specializes in complex medical dermatology with clinical and research interests in autoimmune skin diseases such as dermatomyositis, lupus, and pemphigus vulgaris. Thank you for joining us today.
Happy to be here.
It's really great to have you here. I'm excited to have a dermatologist so I can pick your brain a little bit.
Absolutely. It's one of my favorite topics to talk about. Love learning about lupus, seeing it, treating it, and talking especially with other colleagues about it and non-dermatology specialties.
One of the things that we're always talking about with the fellows and when we see patients in clinic is, really making sure that when we are calling something a malar rash, that it really is a malar rash and not other common things such as rosacea. And I was wondering if you had any tips for us.
Yes. So this is like the age-old question. So it's a great place to start our discussion. The malar rash is the characteristic prototypical rash of acute cutaneous lupus. So when you break down how lupus affects the skin, there's ACLE, which is acute cutaneous lupus. There's subacute cutaneous lupus. That's more of a polycyclic, these annular lesions, sometimes can be even psoriasiform. And then there's other more chronic cutaneous lesions that I'm sure you and the fellows and everyone have come across, like discoid lesions. And rosacea is one of the things which it can be often misdiagnosed as. Even sometimes I'll admit it's quite hard. Rosacea in particular is a chronic inflammatory facial rash that is often photoaggravated, but it's persistent. It can be characterized by that, we call it an erythematotelangiectatic appearance with flushing, for example. But one of the features it has that can really differentiate it is that it actually can have acneiform papulopustular lesions. So the presence of these acne-like papules would not be expected in lupus. And that's not to say that someone with the ACLE malar rash can't have acne and completely try to throw you off. But,
right.
That there's a few other things that can sort of hint you towards one way or the other. Classically, we talk about with rosacea, you may have flushing that is a transient in nature, and extending the rash sort of past that nasolabial fold and onto the upper cutaneous lip is one of those other classic hints.
I think that's really helpful. And I even find it can be challenging because even patients with established lupus can also have rosacea. So trying to help distinguish between a flare and background rosacea as well can be kind of challenging.
Very true. And it kind of leaves you in situations where you're considering, well, do I have to do a punch biopsy on this young woman's face, right? Not exactly a cosmetically insensitive area to do a procedure, but we do them. When I see patients with a new facial rash that even has the slightest possibility of being the malar rash or the, acute cutaneous lupus, I will often first check for let me go in the chart and just see if there's a CBC, something with the recent leukopenia, cytopenias, because if a 22-year-old woman has a malar-like rash, new onset fatigue, joint pain, white blood count of 2.9, then I have no qualms deferring the biopsy and just getting an ANA and doing a laboratory-based workup pending that result. I think you can make the diagnosis without that. What I teach my residents in dermatology is, we need to sort of look on the other side and see how do rheumatologists define and categorize a diagnosis of lupus. So I teach them the ACR and EULAR criteria because, if you can spare someone an extra procedure, if the first procedure didn't really yield much, then if the complement is low and they come back with a Smith or whatever it might be, kind of done your job in securing a diagnosis of SLE based on how the lab results come back.
Yeah, definitely. I think that's really helpful. Then hopefully help, those patients reach both of us for management on both the rheumatologic and the dermatologic side too. You mentioned biopsy, and I think that that's something else that I think is as rheumatologists we're not quite as comfortable with as I assume that you are in the dermatology world. When do you find it helpful to get biopsies in these patients, and are there any tips that we should look for on the biopsy reports, as far as distinguishing between lupus and dermatomyositis, etc.?
Yes, biopsying can be complex. There's a few different situations where it's helpful. Lupus and dermatomyositis can show almost the exact same reaction pattern on histology. And that's usually something we call a vacuolar interface dermatitis pattern. There can be mucin deposition. Some dermatopathologists might comment that the interface change is a little more subtle in dermatomyositis, and perhaps there can be epidermal atrophy. But overall, if you probably blinded the dermatopathologist and showed them lupus or dermatomyositis, many of them might just kind of sign it out as compatible with a connective tissue disease. There are certain eruptions of the skin that are associated with systemic lupus where it is actually helpful to have a biopsy that has features of lupus. These are rare, but I'll give you an example. You can actually have an SJS/TEN like eruption of ACLE or really heralding a diagnosis of SLE. And I've actually had that in a case where somebody has basically what looks like Steven Johnson syndrome, but we were able to use laboratory tests and then a biopsy to also confirm histologically that they had cutaneous lupus in addition to necrolytic epidermal lesions that were more SJS like.
Wow.
There's other overlapping conditions, like there's an overlap of pemphigus vulgaris and lupus. That's called pemphigus erythematosus. Biopsy would be helpful there because you're going to basically have direct immunofluorescence findings that support a pemphigus blister, but then you can also have findings that demonstrate a vacuolar interface dermatitis, and you're kind of clinching that dual overlapping diagnosis. Same thing can be said with Rowell syndrome, ROWELL. That's known as an overlap of erythema multiforme like lesions with cutaneous lupus as well.
Oh, wow.
And yeah, and then there's the list goes on. I've recently seen a great case of bullous SLE. So the bullous eruption of SLE is actually a tense blistering eruption. So it kind of looks like pemphigoid, meaning we get these intact blisters. And for that, it's nice to have that histologic confirmation of that blister that may, for example, show a subepithelial blistering lesion that ideally you want to get an ELISA test. If you have some other proof that the patient might have SLE, that's helpful, whether that's on a skin biopsy of another lesion they have that could be compatible with cutaneous lupus or through laboratory testing.
Are there any other clinical features that would distinguish, a bullous lupus from the pemphigus, etc.?
There are actually. So that is something we run into. For example, epidermolysis bullosa acquisita is something we call EBA.
Okay.
And that is another acquired autoimmune blistering disease that does not have to do with lupus. And it actually is a tense subepithelial blistering disease. And the antibody, or the epitope, I should say, which the antibody is directed against, is collagen 7, which is the exact same one in bullous lupus. But the distribution is different. If you have more oral mucosal involvement affecting the vermilion lips, that's a sign towards actually bullous lupus. Whereas EBA can have really different variations, but it can even be mechanobullous,
Okay.
meaning it's overlying like the dorsal hands and areas where, you're
More
actually
mechanical trauma.
getting yeah, exactly, which is sort of like children who are born with epidermolysis bullosa as opposed to this acquired autoimmune blistering
Autoimmune.
disease. That kicker for a recent case I had was the presence of oral mucosal involvement and extending onto the vermilion lips, blistering. It was a slam dunk type 7 collagen, SLE diagnosis, Smith, dsDNA, very, very elevated.
Wow.
But it was previously thought to be EBA.
That's a really great case and a really great tip, and something definitely to keep in mind. One of the other things that I think has been a challenge is the differences between detecting rashes and managing rashes in patients who have more white skin compared to darker skin. And I was wondering if you have any tips for us in that front.
Yes, this is very important. Erythema is going to be the most important discussion point on that. Erythema, even in sort of clinical trial scoring systems, is signifying active damage, or it's sort of trying to tell us that there's active lupus that could lead to damage, rather. The damage is that atrophy and the dyspigmentation, for example, the sequelae of a chronic discoid lesion. When they're active and bright red, you're assuming that now is a good time to treat to prevent that damage. The problem with erythema is that there's a potential for it to be miscategorized or even under-recognized by clinicians, researchers, etc. In Black patients, erythema was actually more often described as pink versus in white patients, it was described as red using a CLASI scoring system. This was shown in a really good write-up in JAMA Dermatology just at the end of 2024. That's concerning because the pink designation of erythema actually would be assigned a lower rating. So at that point, you're talking about the perceived activity being lower and the associated scoring being lower, which can affect clinical trial eligibility. And skin of color, erythema can even look gray, purple, brown. Take home point, look for these various hues of erythema. Take good clinical photos before you start a new systemic treatment if you are looking at all for skin changes as a parameter of improvement. And, the other thing, this is calling back on our malar rash discussion, is, it would be remiss of me to not mention the heliotrope rash of dermatomyositis and how that differs. While not entirely reliable, that might remember, if you haven't done it, you Google, the heliotropes of purple flower that historically is described as a purplish eruption on the eyelids. In patients who are white or very fair skin, I've seen it look, of course, bright red, bright pink, very, very noticeable. But patients with skin of color, it could just look like a little eyelid dermatitis or post-inflammatory hyperpigmentation even, because that purplish hue really doesn't stand out as much. I know we're talking most about lupus, but given that it's in the differential diagnosis, periorbital edema is something that can be quite impressive in dermatomyositis. And if there is rash there, it tends to hug the sides of the nose a little bit more. So it's very medially based as compared to the malar rash. So that's just a way to sort of round out how you might approach the malar rash versus rosacea versus the heliotrope rash, and consider the underlying skin tones as well.
Yeah, thank you. I think that's really, really helpful points to remember and really critical when we're kind of initially evaluating these patients and making our initial diagnoses. Moving on to thinking about how we manage patients with lupus. I know one of the first things we talk to patients who have skin involvement, and especially photosensitive skin involvement, is the importance of sun protection. And I know when I talk to patients, I probably just give them a general, use sunscreens, but I would love to get your take on what you tell your patients and some of the tips that you give them.
Absolutely. You would think that as a dermatologist, this would be like the majority of the time of the visit, but there's so many things we have to talk about in such a short amount of time. These visits feel like they could go for hours, and you could talk about photoprotection for 20 minutes. It's something that is so important, and I try to stress it. As a example, let's pretend that I'm having this discussion with a Black woman who has maybe some post-inflammatory hyperpigmentation from some old rash that they had. If she has lupus, we have to consider that we need to cover both UVA and then also UVB. UVB is mostly blocked when we're talking about windows. However, a certain amount of UVA can come through even like car windows. So there have been some individuals who, depending on their degree of photosensitivity or even occupation, may go far as installing tinted windows, which, depending on what state you live in, might require medical clearance for that. It does move beyond UVA and UVB because in photo testing studies, they've actually shown that a really lot of lupus patients also have sensitivity even to visible light, which is fascinating and interesting and scary because how do you avoid that, right? How do you avoid visible light? You've got, aside from the sun being a huge source of it, all these indoor bulbs. There is someone smarter out there than me who could talk about the different light bulbs and how they can affect lupus, but that conversation exists. Apparently, LED lighting, light emitting diode bulbs are preferred. They don't emit any ultraviolet radiation, whereas the CFLs or those compact fluorescent lamps or even the halogen bulbs can emit reportedly low levels of UV radiation and enough that might even cause a little bit of erythema. So, I mean, you can really get in the weeds, right? These are not conversations I have on a regular basis with my patients.
But in a really refractory patient, it might make a difference.
It may, that's correct. If we want to talk about general things, there's always photoprotective clothing.
Mhm.
It is much better these days, right? A lot of these outdoor stores nowadays have, I don't fish, but I have a lot of like fishing gear now. I walk my dog in North Carolina at 1 p.m. or, over my lunch break, and the UV index is like 12. So I will burn out there in like 15 minutes. So you can, rather than wait 15 minutes for your sunscreen to rub into your skin and be activated, I just throw on one of these long sleeve shirts and then a wide brim hat, and I'm pretty protected. So that's something I tell my patients about, is having readily available clothing that is loose and is comfortable to wear even on a hot July day. Because for some of these conditions like lupus, dermatomyositis, it really doesn't take that much exposure. Joe Urizzo, he founded our department. It's always interesting hearing him talk to patients. I trained here at Wake Forest, and he always says a short walk through the parking lot can be all it takes, and probably some truth to that. It seems like I've definitely seen patients flare from spending way too much time in the sun, but it can just be even a short dose.
Yeah, we face that in Southern California as well. So
Yeah, yes, I'm sure. To bring it down to the very basics, now there's sunscreen, right? So we've talked about how potentially lupus patients are sensitive to UVA, UVB, and then visible light. What's going to cover those three? The answer is going to be a broad spectrum mineral-based sunscreen with something like iron oxide in it. The added iron oxide basically is giving you some of that visible light coverage.
okay.
The original zinc oxide formulations are more so just broad spectrum UVA. Going back to our example, say we have a young Black woman. What's great about these sunscreens too is, and it's so great that they're marketed in different formulations now to sort of match your skin tone, all the way from like Fitzpatrick 6 down to someone who's 2 or 1. You can choose one of these mineral-based sunscreens that have a zinc oxide tint and find one that will rub into your skin without leaving a cast that looks unsightly or
Right.
something you don't like to see.
So finding something that patients can actually incorporate into their daily life and then forget about it is actually probably the most helpful thing.
That's right. And it kind of goes the other way too, I will say. I mean, personally, when I go on runs outside, right, I wear like the Equate Walmart brand chemical sunscreen
Right.
because I know it's going to just be hot and sweaty. And like, it's not like I need some elegant sunscreen for my face. But, it's also cheap, and, adherence matters. So ultimately I walk them through the benefits and the annoying parts of different sunscreens. And then I, have them sort of adapt a way of using them that fits with their life.
I was wondering if you have any tips on when you use topical corticosteroids, which potencies you use, etc.
Yeah, certainly. The most important word that will come back again here, and this is showing who I trained with, Steve Feldman, dermatologist here at Wake Forest, is that word adherence. We can talk about potencies, and I will. But ultimately, perhaps the most important thing to talk about with patients is what they want to put on their skin, right? Some people like greasy ointments. They think they feel soothing. Some people, it's the most annoying thing in the world. Some people just prefer a certain feel on their skin, and whatever they prefer is what they're going to keep using. So if you gave someone over-the-counter hydrocortisone, but they liked using it, that's going to work better than giving them clobetasol thousands of times stronger that they don't like using. Ultimately, that's something to consider. There's 2 prescription corticosteroids that are always going to be safe to use on facial rashes or lesions when they are there. That's what I tell patients is steroids are not moisturizers, but when you have a rash, perfectly safe to use once to twice daily.
Okay.
And that would be, right, your hydrocortisone 2.5% cream, lotion, ointment, whatever you want to do. And then there's a desonide. So that's DESONIDE, and that's a 0.05% formulation. Perfectly safe to use on facial rashes. The flip side of steroids is going to be your topical calcineurin inhibitors like tacrolimus ointments, etc. And those work great on the face, and they don't have that really long-term overuse, right? And at the very center, some of the discoid lesions already have atrophy, so you want to be using something that could add to that. Sure, just end the conversation and give a tacrolimus ointment. You won't even worry about it. The dirty secret is, I know dermatologists who have used clobetasol on their face.
Oh gosh.
So I will say, because one, steroids on the face can cause acne, steroid acne, and that's not good. But as far as the whole atrophy thing goes, clobetasol might be a stretch. But if you use a potent or a very potent steroid ointment on a very active discoid lesion on the face, like a fluocinolone 0.05% under supervision, and when it's there, that's going to be fine, right? It's as long as it's not prolonged use for months on end.
Right.
But it comes down to, do you have enough time to explain that? Is the patient trustworthy to follow those instructions? But that's just something to consider. Last thing I'll say is discoid cicatricial sort of scarring lesions on the scalp. Ointments work actually great. We have a lot of patients who really don't mind using greasy ointments on discoid lesions on the scalp, whereas others might prefer like a clobetasol solution, like a liquid that sort of rubs in and evaporates just due to that alcohol component. Then lastly, there is a oil-based one, and that is fluocinolone oil. So not fluocinonide, but it's FLUOCINOLONE. So fluocinolone oil, great for scalp lesions and also conchoidal bowl discoid lesions. So there's a otic formulation of those drops. So you would look up, fluocinolone oil otic drops, and that's great.
I'm kind of thinking somewhat along those same lines. When do you use or move to oral agents and kind of either in lieu of or in adjunctive treatment with topicals?
When someone has SLE, your access to therapies is very expanded. If from a skin perspective, they just have a few discoid lesions, honestly, for their sake and just to be a steward of the system, right? I'm not going to do an anifrolumab infusion
for a few skin lesions.
Yeah, if their joints are fine and their kidneys are beautiful, they feel well otherwise, but they've got a couple skin lesions, if it's localized, a few lesions, you should be able to use a combination of topical therapies, or they could come into the office and I could inject a little bit of intralesional triamcinolone. Mm-hmm. Something to consider with like DMARDs and hydroxychloroquine is some of that data suggesting that, and I know I'm sort of bouncing back, but if someone has like isolated cutaneous lupus, I think there was a recent study I read and some other versions of this idea that, using an antimalarial can sort of delay the progression to eventually develop SLE. Some of our patients with isolated cutaneous, they might still have like an SSA. That SSA has implications with pregnancy and other things. And I would want to be on an antimalarial probably if I was them. I just would, at that point, I just wonder with those circulating antibodies, like they probably have some systemic autoimmune interferon-based disease going on, even if it's really just manifesting mostly in their skin. And then, I think for hydroxychloroquine, that's going to be your first line. We've all had that discussion where we accidentally freak out a patient about the retinal monitoring.
Right. It's an ongoing discussion with all of my patients.
Yeah, and then you quickly, because you're like, well, I want you to see a baseline eye exam, but I always try to walk it back by saying, listen, that's just a baseline exam, but the real monitoring begins after 5 years of taking it, according to the societies, and you might not even be on this 5 years. And then other drugs, dapsone, reserved mostly in my case for bullous lupus. Some people will use retinoids for different lupus lesions, discoid lesions, methotrexate, mycophenolate, all have their own things that, again, sometimes have to walk back some package insert things that scare people. And I don't mean to. I understand that the medicines can have serious side effects and can make people feel quite unwell, and they all have their adverse effects. But I always try to explain that, in some of our, at least when I'm prescribing some of these drugs, we're using more anti-inflammatory dosing of methotrexate, right? We're
Right.
not
And
doing,
not the anti-cancer dosing that the product labels are based off of. Yeah.
yeah. So there's always those discussions.
Yeah. And certainly I think that those agents are used even more commonly when we have patients having other systemic manifestations. And, I know we always are in dialogue with our dermatologist to kind of see what might be the best medication to kind of catch all aspects of their lupus activity.
Yeah, I love working with our rheumatologists here at Wake Forest. They're an awesome department, and we refer back and forth to each other all the time. It feels like we're always sending messages, on the patient portal to each other. And a discussion that we've had is often is, well, when should the patient get belimumab and when should they get anifrolumab?
Right.
I can't speak for every dermatologist, and I just hope this is maybe helpful for any rheumatologist listening. Maybe this is just like my sector of the world or my only opinion, but it feels like most dermatologists who see lupus these days prefer and are more impressed with anifrolumab when it comes to skin response. Whereas I know that the underlying systemic lupus and extracutaneous manifestations might drive the rheumatology team to be like, maybe belimumab, given the nephritis or whatever it may be. Right. There might not be enough data on anifrolumab to sway them that way.
That's right, exactly. Yeah, so yeah. I do think it is always kind of a back and forth. And again, kind of taking the overall picture, what might be the best kind of combination to capture all the disease manifestations that are going on.
Absolutely. And of course I want the skin to be as good as it can, but
right.
The kidneys are pretty important.
They're important
too. So ultimately it's that discussion and sort of seeing the patient's goals, and also as a group, all the consulting physicians feels, important to protect in the patient.
Thank you. I think we have really had a lot of great tips today. And I really want to thank Dr. Edminister for being here today.
It was a pleasure, and thank you so much for inviting me.
Thank you for joining us today. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on systemic lupus erythematosus. This is Dr. Maureen McMahon for the Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Systemic Lupus Erythematosus podcast series with our host, Dr. Maureen McMahon. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on systemic lupus erythematosus.